No one told me I'd have to get this started, but I guess I'll take the reins on it. So I appreciate everybody coming. I'm very excited to have such a nice group to get this BHASe conference kicked off. I'm looking forward to meeting every one of you individually. We didn't really, we talked about this beforehand, and it's kind of the first meeting of the young professionals put on by Benesch. And, we're all kind of in this industry together, starting off learning about behavioral health, and thought it'd be a good idea for all us to get together and kick off the conference and see, what areas do we need to focus on? What are areas that you guys are challenged by that we could help out with? And just kind of have a group conversation about what we could do to further the behavioral health industry. So I'm going to start off, introduce myself, and then we go through and give introductions and open up the floor for conversation. And we can make this more casual and not a panel and group conversation, however you guys feel would be best. So I'm Berman. I'm the CFO for New Vista Healthcare. We've been in the behavioral health industry for about 8 years now. We own psych hospitals and drug rehabs in Ohio and Indiana. And besides for those, we've opened up a bunch of ancillary companies in the behavioral health space. One of our newest ventures is BHX, which Jacob is our co-partner. And we're proud host of the BHASe conference. And we're focusing on M&A work as well as back office, financial reporting, revenue cycle, and anything that could help your business get started in the behavioral health industry. Cassie.
All right. Hi. My name is Cassie Sikorski. I'm from Benesch Law. And again, just want to welcome everyone and thank you so much for attending this panel. As Joe mentioned, this is just really a great chance for us to kick off this wonderful conference and to make some connections so that we can all, really thrive in this behavioral health industry together. So a little bit about me. I'm an attorney with Benesch. I work in our Healthcare Plus group where I specialize in regulatory and transactional healthcare work with a behavioral health focus. I do a lot of work in the substance use disorder, mental health, and other related services. Really, I like to think that my favorite part of my job, just absolutely the thing that gets me going, is really working with entities and working with facilities to help them provide the best services that they can. It makes me very happy when we can solve an operational or a structuring issue that really gets the services to the people that need them. And so while I'm an attorney, I like to think of myself as a consultant to make sure that I can help move any of those regulatory, operational, structural, or other issues. And I think we all know there's always an other issue. And really getting them so that we can provide the best behavioral health care to the patients that need it. So I'm very much looking forward to meeting all of you as this conference proceeds, and thank you for coming.
Hi, everybody. I'm Jonathan Grenier. I'm the lender on the panel. I'm the managing director at Forbright Bank. We're a Maryland-based bank, and I work in Boston, actually, but we have a national lending presence. Most of what we do is in the behavioral and skilled nursing and seniors housing spaces. We've been really focused on behavioral for the past 4 years or so now. As all of you know, there's just insatiable demand for behavioral health services right now. And so we're very focused on meeting debt capital needs of folks that own and operate behavioral health facilities. And that's a bit about Forbright Bank, but very excited to be here. And I'll turn it over to Jason.
Thank you. I'm Jacob Lynch. Dove already told you everything about me, so that was easy. Glad to be here. Glad to see all of you. Excited to talk, learn from you, and answer any questions you might have. Anything I can do for you. I just do M&A investment banking in the space, all in behavioral health. That's all we focus on. So any ancillary industries as well, but it's all behavioral health related, whether it's buy side, sell side, consulting, the exchange that we'll talk more about later this week. But any service that we can do for you in a behavioral health capacity, we're happy to talk about. So the new company is called BHX, New Vista, Dove. They're our partners, and yeah, looking forward to talking this week. How do we kick this off?
Does anyone have any questions? I'm going to put you guys on the spot. You can raise your hand if you like. what is the hardest way to, what is the most difficult thing to penetrate behavioral health space? Is that correct? So I would say, just a little bit about our company. We started off as a nursing home provider. We were in the nursing home business for 30 years. And I would say one of the biggest challenges we had when it came to the behavioral health space was how different it was than running a nursing home. We utilized a lot of the tools and the ways of thinking, the regulatory pieces from the nursing home industry, and it was very different. And that was, I think, for us, the biggest surprise getting into behavioral health is just knowing what are the things that are going to get you in trouble and preparing for those, and making sure you have a plan.
That's why you call me, so I tell you how not to get into trouble.
Exactly. So I would say that's really the difference, and just a different way of managing the expenses versus a nursing home model. It's a different business, and I think that was, again, one of our biggest pitfalls in penetrating the behavioral space is going at it with the nursing home mindset and bumping our knees along the way and figuring out it's a whole different industry and redesigning what it means to be a behavioral health company.
On the legal side, I think one thing that is important to note is just how heavily regulated behavioral health is. And we talk about behavioral health like it's one concept, but within behavioral health, we have so many subsets and so many different types of facilities, services, delivery models. And I think what is surprising oftentimes to our clients is how different those different, niches of the industry can be and how different the requirements are for starting those up. So oftentimes there's a great idea, there's a great company, there's a great area that needs those services, but there's a lot of things that have to go from identifying that need and that target to actually getting that up and running. And I think that's something that, especially for someone who hasn't worked in behavioral health, but specifically in that type of behavioral health, in that state, with that delivery model, just changing one of those little variables can make a huge difference on the needs for getting those services started and running. So I think that's something that we are all aware of, how varied this field can be. But when you actually get down to the nitty-gritty of starting it, that's often surprising for people in terms of how different it might be from their previous ventures in healthcare.
Yeah, I would add, on the lender side, we've faced a similar challenge, just understanding how nuanced behavioral healthcare can be, varies by state, by market. They're all different care delivery models and reimbursement models. And so whenever we look at a new transaction, we spend a tremendous amount of time understanding what that business model is, what the management team's track record is with that business model. And that's a key part of our underwriting. But for someone who's new to the space, we spend a lot of time sitting down with the management team in person, understanding what their experience is elsewhere, and what their business plan is for their new endeavor.
I'd second all that. Obviously, capital would be the first hurdle, and the legal part after that becomes an issue. I got lots of horror stories of clients of mine. I had one in Arizona that took him 1.5 years to put a sprinkler system in. They didn't know he was going to have to, and like $300,000 to do that. There's a lot of those things that you don't learn until trial and error, right? And it is very different from other spaces. So people come in and they say, behavioral health is killing it, good multiples, good returns, good reimbursements, let's do it. Let's make a bunch of money. And they find out it doesn't work, right? They can't collect the money, can't get the patients in, all those things. It doesn't just transfer from one industry to another. And there's no necessarily guidebook or instruction manual. So it is some trial and error, and then making sure that you're seeking the counsel of some wise people that have done it before, right? That's who I'd get in touch with if I was going to start one today. The regulatory landscape is always changing, and it continues to. So it's not a tough one to begin, but it can be a great one if you do it correctly.
So I'd say our first mindset was, let's use a lot of people that were successful, like operators that were successful in skilled nursing, and let's apply them in the behavioral health space. So one thing I've learned in the behavioral health space is people that are in behavioral health are very proud that they're in behavioral health, and they're behavioral health people. So once you start with skilled nursing mentality, it doesn't really work. Like, if you try to be cheap on labor, that backfires a lot of the time. Like, the reimbursement is higher in the hospital space and the SUD space, the nursing homes. And because of that, like the whole way you look at labor, you look at expenses, it runs at a very higher level expense model than I would say in the nursing home business. Nursing home, I had a background in nursing homes. You're always pinching a lot of pennies, trying to be as frugal as possible to really maximize the reimbursement usually. And behavioral health, I feel like everything costs a lot more money, from making things psych safe and making sure you have, the right behavioral health, employees, which are more expensive, and try to utilizing someone just has a nursing degree versus a behavioral health nursing background. It makes a big difference, just how they interact with the patients, being afraid of the patients. There's a lot of factors that people that don't have that behavioral health experience puts up a lot of barriers, and it's just a different mindset in the operations. Mostly, I think around those points of utilizing the reimbursement to not be afraid to spend money, and I think that's a big learning curve for us. Go for it, Abby.
So Jonathan, as a capital provider, the market has surely changed in the last year or two, and sort of tightened up in capital that's available. When you're assessing making a loan to a behavioral health company, what are the 2 or 3 biggest things that you look for that differentiate one provider from another?
Yeah, great question. And just so everybody could hear it, it was basically acknowledging that the capital markets have really tightened up because rates are much higher, banks are pulling back, which is true, and then asking what we look at as lenders when we assess a new transaction. I think first and foremost, it's character. And how do we assess character? It's really based on the track record of the operator. Are they an operator that has a history of clinical issues in the markets that they operate in? Do they have bad press tied to them? Do they have a history of litigation or regulatory issues? Those are all major red flags for us. I think in healthcare, we can all acknowledge that bad things happen. And so part of what we look for is that we want to be making a loan to someone that is going to overcome those challenges that inevitably will arise. So we're looking for a true partnership with our borrower. Beyond that, we look for experience. So understanding, what their experience is in that state or region or with that care delivery model. And then 3 is really assessing the financials of the transaction. Does it underwrite? Do the multiples make sense? Does the pro forma make sense? We do a deep dive into reimbursement rates, look at comparable sales in the market. So we do a very robust underwriting. There's a lot more we look at, but those are, I think, 3 of the bigger areas that we focus on. So, yeah, tough to parse the 3 out. I think they're all very important, but yeah, probably roughly in that order.
And I actually have a follow-up question for you. You've mentioned that you have been in the behavioral space for about 4 years, and so those 4 years have been absolutely incredible in terms of volume of transactions. Can you talk a little bit about what has changed over the past couple of years and what you look for now that maybe has changed since, let's say, 2021, when we just saw an absolute explosion in this area?
Yeah, that's a great question. Over the past 4 years, I think we've probably all seen this, but there's just been an explosion of demand tied to the opioid epidemic, tied to COVID-19. I think there's just significant demand that's not being met for mental health services. So in some ways, that's made our life somewhat easier as a lender because there's a lot of funding out there from the government. There's an acknowledgement that these are major societal issues that we face, and there's so much demand. So that's made our job easier as a lender. I think that the challenge probably is that we're seeing new ways of delivering care being developed. We're seeing new operators in the space, which is a great thing, but challenging for us to underwrite those opportunities. So that's something that we've been grappling more with. Thanks for the question.
Thank you. When adding a new location in the same state, can you talk about a little bit what the upsides and downsides are to either keeping it within a single entity or multiple entities?
Yeah, I'll kind of jump in with some legal perspective, and I think these gentlemen will have some input too. You know, the benefit of operating within the same state for a new facility is just huge in terms of the legal and regulatory, the structuring, the concerns that you're going to have when you're setting this up. But to your specific question is, are we setting it up as a new entity? Are we setting it up with one common owner? And, you know, on the legal side, I think it's a pretty complicated question that there's not a one-size-fits-all answer to that. But some of the considerations that I would point to are, what are the other operations involved in that company? What other subsidiaries, what other affiliates are there? How many different entities are you going to be juggling and dealing with to try to put under one umbrella? Another thing that you would need to pay attention to is what type of entity and what type of services are being provided. Not all medical behavioral health services can be provided by each entity type. And so when you're structuring, you have to say, in this specific state, what am I allowed to do? What kind of entity can do that? What restrictions am I going to have on the corporate practice of medicine side? That might make it more advantageous or not to structure your entity with a holding company. So it is I would say it's a very fact specific depending on what your entity looks like. But it's one that, at least if you're doing it within the same state, you aren't going to have to deal with those questions on multiple state levels, which makes it more specific to your company, your financial history, and your goals within that state.
I'll say one thing, you know, we think about when we're going to make multiple entities or keep it the same entity. You know, one of the benefits of keeping all under one parent entity is, again, it's usually going to be one, just like, you know, if you're joint commission or through the states, just adding a location versus going through a whole nother survey, which again is a speed to market approach, as well as a lot of times with the contracts with different payers and things like that. You don't have to go and get new contracts with all the different payers because you can kind of keep it all under that one entity. But you have to weigh, is the risk worth it? You know, if something happens at that one facility, whether it be a joint commission survey, a state survey, and you get shut down, then it really shuts down your whole company, versus being able to kind of spread that liability. So we always factor what, like you're saying, what type of services they're providing. Is it a psych hospital? Is it an outpatient clinic? Is it a treatment center? And then from there, kind of determine where it makes the most sense for us to create new entities.
And I would just add, from a lender perspective, sometimes the way we'll get comfortable with lending to an entity that's new, that's a startup, is we'll cross that with a performing facility. So sometimes it can work to your advantage if you have an entity that owns a stabilized property, and then you can cross that with a new entity that's not stabilized. That's a way to sometimes get financing lined up.
Jacob, when it comes to selling the business, does it make a difference if there's multiple entities or one entity? Does that make a difference?
No, I mean, it'll be more of a headache, right? If somebody's got to buy 7 different entities in order to get something, it might be a headache, but won't make a difference value-wise. What you said is exactly the way I would have answered that. I mean, you're minimizing risk if you got different entities, right? So if one place makes a mistake, screws up, it doesn't sack the other one. On the other hand, licenses, contracts, accreditations, et cetera, easily transferable, right? If you're in the same entity, so it makes it a little easier that way. That'd be my answer, but not much from a value standpoint.
I think we had a question right there.
Hey guys, what are you seeing as the major drivers of multiples in the last year or so? And sort of a follow-up to that is, what are some mistakes that you see folks make when they go to market?
Driver of multiples is not a loaded question, but there's a lot of them, right? So obviously, supply and demand is always the driver. What's happening in the public markets? Obviously, we still have more patient demand than we have access. So it's good for the market. As far as the multiples reacting to that, there was quite a dichotomy coming out of COVID, right? So some of the ones that thrived during that season, multiples exploded. Those that survived went even further down. So we got even more divergence. Consolidation started to speed up quite a bit, and some of the larger guys started to gobble things up. So multiples grew, but only for quality assets, if that makes sense. So quality of care, outcomes, results are a big driver. Geography, location, and how many, multiple sites, et cetera, are a big driver of multiple. But mostly, as I was saying, it's the supply and demand of what you've got as to what's available. There's plenty of money wanting to be deployed into the space. It's a question of, is there enough quality clinical care there to support it, to be available. Your other question was, remind me? Oh. Yeah, those are all over the board as well. And I don't want to give you a bunch of horror stories. I've seen some recently. Yeah, I think the major one or the biggest one I can always see blanket is just not preparing, right? They're doing it on a moment's notice, right? Like something came up and I'm making an emotional decision. Let's sell, or let's not, so let's buy, or whatever it might be. If you've got a plan, if you've thought strategy, if you've planned some things out in advance, then you can make a much more unemotional, rational decision. I need this for this purpose. This is what I have to get. Well, I have to be at this level at that time. And then find the right person and appeal to what they need, right? If I find this is the buyer, this is the culture we're going to match, this is the value I need to get, what do they need? Well, I'm going to supply that. I'm going to provide that for them. Maybe they're missing outpatient, or they're missing this geography, or they're missing this insurer, their contract, whatever it is. I'm going to supply that. I'm going to be more attractive to them. The mistakes, I think we can all probably speak to them. There's plenty legally, goodness gracious. And Doe's probably, seen and experienced some, and some of them that he's looked at. But yeah, we can talk later, and I can tell you 100 mistakes that I see every day.
I would say the most common mistake, from my perspective, that kills the deals that come my direction is people having unrealistic expectation of the value of their company, and especially coming out of COVID. A lot of businesses were losing money, and they have strong financials before COVID, and they want to go to market and say, value this company based upon pre-COVID numbers, or look at our pro forma in the next 3 years we expect to be here, and try to pull a multiple on that number. I think that usually is where I see a lot of deals fall through, is not coming to the table being realistic of what the operation is currently, and having realistic expectations of what the company's worth.
And speaking about realistic expectations, timing, you mentioned that people see a great idea and they make an emotional decision, they want to go for it. On the regulatory side, it's often a much longer licensure and regulatory onboarding to get these services if you are a new provider. And I think that's something that we often see when we are dealing with someone who is new to that specific industry. This isn't something that's going to happen in 3 months. This might not happen in 6 months. There's oftentimes a really huge regulatory component that drives the timing of your kind of access and ability to provide these services. And that's something that it's never fun to hear that it's going to take a little longer than you were expecting, but it's a really important conversation to have at the outset so that people can have realistic ideas of how long licensure takes, how many licenses you might need, and all the regulatory concerns that go into that transaction or that new venture beyond the typical just business concerns of startup.
Jacob, one follow-up question for you is, over the past 12 months, when you look at the market now compared to 12 months ago, have you seen a shift in a buyer's willingness to consider pro forma performance? Meaning 12 to 18 months ago, did you see buyers sort of more aggressive in how much weight they'd give to a pro forma in a transaction, or has that stayed the same?
The weight they put on it probably stays the same, which is not a lot. So I can give you projections for forecasts all I want. Most people are, what have you done for me lately? Show me numbers that have happened, not numbers you say could happen. If they can happen, why aren't they happening? That's easy for me to say, easier said than done. I don't operate, so I understand it's difficult. I just mean the pro formas, there's not a ton of weight put on them. In my experience, or the buyers that I deal with, those pro formas that I do see have changed, obviously because of interest rates, right? So I can project the same amount of business, but what somebody's willing to pay me for that has changed quite a bit over the past year, obviously. And one other, to touch on, mistakes that you you guys mentioned as well. Just I see a lot of my clients sometimes, even if I've coached them or tried to explain things, set expectations appropriately, often they're going to revert to whoever their trusted advisor is. Might be their brother-in-law's plumber that, lives down the street. And that can get them in trouble, right? So, I mean, if you go to market, if you have a whole plan, like this is my strategy, this is what I need to get, this is who I'm going to sell to, et cetera, this is what I'm trying to achieve, it's a much better strategy than just emotional, quick decisions to, I need to do this. Not to say that can't work. There's times when the market's hot, but having a plan is a much better idea, much better strategy.
From a budget expense perspective, on like an inpatient type model, detox residential, where do you feel are the best opportunities for cost savings without compromising quality of care and quality of facility? Which parts of the operation do you find have the best opportunity to cost save?
Not labor. I was just saying not labor.
So I would say your biggest expense is always your labor. So, finding creative ways in your labor structure to minimize expenses is always going to be your biggest pickup. So understanding, RNs are hard to find. You're trying to maximize LPNs, maximize techs in a way that you can cut down on that labor cost. We've looked at outsourcing to other countries as a way to save money on like a position like an intake position, like answering phones. Utilizing call centers overseas is another way to cut down on your costs. Labor is really your biggest area of savings. Dietary is another area that we focus a lot of energy on. There's a lot of wasted costs there, especially nowadays with food going up as much as it has, trying to figure out the most cost-efficient way to feed your clients, and that's always something we're highly focused on. We try to focus on all the expenses, as best we can, everything from office supplies to the labor. All of it's important, but I would say, definitely the biggest pickup is in the labor area, trying to figure out non-clinical positions that you could get away doing a little cheaper, and also utilizing different licensures. Clinicians can have different levels of licensure, trying to utilize CDCAs and things like that have a little bit easier to come by and less expensive.
I think properly understanding how to utilize paraprofessionals and what services they can and cannot provide, that's something that absolutely any facility and any entity needs to understand very, very clearly. One, to avoid any legal or ramifications and liability, but two, in terms of leveraging that cost savings, understanding who can do what, and if there is a lower cost option for some of those clinical roles, really understanding how you can use that to leverage some cost savings in areas that still ensure that you're providing the right services to patients at a high quality level.
Dove, I'm curious from your perspective. I mean, as a lender, we've seen agency staffing as probably the number one challenge on the expense side that most operators are dealing with right now. Has that changed at all for you over the past 12 months? Are you hearing that staffing pressures are getting better, worse, the same?
Well, thank goodness now it's gotten better. I would say about a year and a half ago, 2 years ago, was like probably the height of the when it was terrible. It has definitely gotten better, but we've done a lot of creative things to try to cut down on agency. One is, again, utilizing LPNs over RNs. That's a big thing. Or try to utilize more techs. Try to use the RNs using them at the height of their license instead of utilizing them for tech type of work. We utilize them at the height of their license, and also trying to be creative and creating PRN staffing, things like that, to try to get away from agency, maybe paying a little bit more in a shift diff, in order to avoid bringing in agency, which just kills you because they have month contracts usually, and once you get them in your building, it's very hard to get them out.
I think you've probably got new care delivery services now, right? Like telehealth is an easy cost saving, I think, or more efficient. I think there's a lot of dollars left out there billing wise, revenue cycle management. I think there's a lot of places you can probably clean up some expenses and costs to be more efficient that I see every day.
Dove, this is really for you. How do you create predictability from a revenue cycle management perspective, as well as create a profit and loss by month perspective, considering the revenue kind of flows in when it flows in?
guess the first, I just understand your question. I don't know if I fully understand your question, but I think the first step is to understand by putting together a budget, proper budget, and creating proper financial statements that allows you to see really what your cash flow is going to be. If your financials are not being reported correctly, you're not going to know where you're going to be at in a cash perspective. And once you have your financials coming out on a regular basis and having proper financial statements, making sure they're accurate, is really looking at your bank month over month. What we focus on is the cash goal. What percentage of our cash we're collecting versus revenue, and knowing where that number is at, because that's going to really tell us, looking at the bottom line, if we're expecting X, we're expecting to collect 98% of that that month, the following month. So that's kind of how we're, managing in live time, and we're billing on a regular basis. It's crucial not to mess up your billing cycle. If you're billing every 2 weeks, just to miss a week, you're gonna put your whole cash flow off, and you're gonna get behind, and it gets nasty very quick. So it's definitely staying on task, making sure you keep to your billing cycle. If people are away, having backups and systems in place that you don't get yourself behind. I don't know if that answers the question, but it's a general concept.
Hi. In terms of an exit on an outpatient facility, does it help to own the real estate, or does it make a difference if you're on a lease?
If I heard you right, does it make a difference value-wise whether or not you own the real estate for an outpatient facility? That depends on the buyer, right? There's probably some in this room that are buyers that want real estate, and to figure out how to make them produce income. There's probably some in here that are operators and don't want to have anything to do with real estate. So do I think it's a benefit to you? I think so. I think it's an asset that's very income producing, but is it going to make a big difference? Definitely not in the value of the business. It's usually not a separate transaction, but it's a separate piece of the transaction, right? So if I'm going to give you 7 times your EBITDA for your business, whether or not you own the real estate, that's a separate thing, right? Because I'm going to give you the market value of the real estate, the transaction value is staying the same. Does that make sense? So that all depends on the buyer, whether or not you've got real estate. I've got some that'll hire us buy side and say, we're looking for real estate. We want ones that are owned. Maybe they've got a 1031 tax issue. So, right, they can roll, say they sold a SNF, right? And they want to roll that money into something, not have to pay taxes. They're looking for something to buy. Then it matters, right? Then you're a better target. But just as far as pure value, no, doesn't make a difference whether or not you own it.
I want to see how Jonathan answers this, because one of our challenges in this is that if you buy in the operations only, is how do you get that financed? Usually when you have the real estate, it's a lot easier to get it financed, and if you're just buying the operations, it's hard. So I'm waiting. Jonathan tells me the answer. I'm fair game for any operations.
I was thinking about how to respond to this question. I think in general, it is easier for a bank to finance a transaction that has real estate attached to it. But with your question specifically, I think with an outpatient location, if you're talking about a piece of real estate that has, sort of all different, a number of different uses and is not that unique, then I think we as a lender have to look at it more as what's the market value of that real estate for sort of any use in that market. I think where we get more comfort with real estate being attached is if it's think like a former LTAC or a former SNF that's been converted, and there's real value in the real estate in the sense that it's tough to replicate. Maybe there are zoning issues. It'd be tough to find a building that's that large and specialized in that market. That's where we get more comfort from having real estate attached. So hopefully that somewhat makes sense, but.
Local supply and demand is always important, but unlike in SNF, where people will get on a plane to go to different behavioral types of facilities, how do you choose what state to enter? And I assume, and maybe you could talk about the regulatory differences amongst, I assume it varies. So two questions. As an operator, what are you looking at to find the right location? And from the regulatory side, how does it differ state to state?
Well, I'll jump this off. There are a lot of considerations from the legal side. As I was mentioning earlier, there's certainly different barriers to entry to providing services in different states, and understanding which states are more highly regulated and which ones are a little more business friendly or don't have as many of those regulatory burdens is, on the legal side, something that's really important at the start of any new venture. And I'm sure you guys would agree that on the operator side, you are looking for something that is not necessarily the most highly regulated state, just in terms of that entry point.
Yeah, correct. If the state's putting up a lot of barriers to get opened, we want to shy away from that. It just makes it, you already have enough of a challenge opening a building, getting patients there. And there's enough operational challenges that if the state's a barrier, it makes it really unattractive for an operator. I would say, besides for looking at regulatory complexity of the state, is also looking at the need of that state, trying to do an analysis of need, population, how many high, is there room for more than one location? To go to a new state and get comfortable with the regulatory bodies, and then only open one location in that state, is difficult versus being able to open multiples in that one state. And really, a lot of it comes down to reimbursement. What is the reimbursement in that state? If they don't reimburse, unless you're doing a commercial or self-pay, but if you're relying on Medicaid and Medicare, making sure that Medicaid reimburses in that state, and then what is that reimbursement, and making sure your financial model works with that reimbursement.
I guess, Joe, probably for you first, but as you think about the future of behavioral care, right now it's very fragmented. There's not a lot of cohesion. If you think about skilled nursing, you can go to Medicare.gov, you can find a facility, you can look at clinical ratings, what have you. How in the future do you view behavioral care in terms of the consumer? How's the consumer going to be able to find you and know that you're the right provider for their need? And how do we then track to make sure that people know, hey, there are beds available? Right now I think you're hoping to get a bed available, and that's the best you can do. But I'm hopeful in the future, we'll be able to be more differentiated and specialized. So how do you view this, and Jacob as well, like in the future?
It's a good question. I think, the first step is having a conference like this, getting behavioral health out there and getting a group of people like this together to talk about growing the industry and having more consolidation and trying to get people to do deals and grow the industry, and just talking about these challenges and subjects really, like, to me, the first step. It's been going around for the skilled nursing facility for a long time. And when we first talked to Hershey about putting on this conference, there isn't really a great behavioral health conference that, like we were saying before, there's so many areas of behavioral health that focuses on everything. There's an ABA conference here, a psych hospital here, different types of conferences, but having one conference that can address all the needs of behavioral health didn't really exist. So first of all, thanks to Hershey for putting on such a conference that we can get together and discuss these challenges. And I think it all is going to really come from the need. Unfortunately, you read about in the news and hear about all the time how many people are suffering with mental health issues and substance abuse issues. So, once that continues to happen, then the government's going to have to step in and help create the health system and make it easier to get these facilities open. There's some states that still don't have Medicaid reimbursement for substance abuse, so it makes it challenging to open up more locations, to make more beds available for that type of population. There's a lot of commercial and self-pay type of facilities, but not everyone can afford that. So, the more that the government realizes the need and makes reimbursement. We got approached by a state that wanted to deal with psych patients who were, in the state hospital. They were, got locked up by the state and they had to go to a psych ward. And now they're 80 years old and they don't need to be in a prison type psych hospital anymore, and they don't know what to do with those type of patients. And I think the more these type of issues keep coming up and the states realize they have to do something and the reimbursement becomes available, then it's people like ourselves, the operators, that can create programs and facilities that can take care of them, and that'll provide more need and more of a path on how to take care of people. I think without reimbursement, it's hard to figure it out. We can create it, but if we don't get paid, it's hard to make it work.
I mean, think the results and outcomes that we start to track, or we're trying to, is going to move that forward. I don't think ranking really does anything yet. We don't know what that is. I think value-based care will help. I think people will be able to search from their provider who is the best or where should I go. I think you have quality service in your own community. We're getting there. And while the question's valid and it's spot on, that is really the issue. If you think about where we've come from or what this was when I started getting involved, it's night and day difference, right? There's no more, I shouldn't say no more. There's not as many bad actors, body brokering, the labs, the fraud, all the things. Well, the Google AdWords thing, right? So we're not stealing each other's calls or whatever anymore that I used to hear about. Like, you know, we've come a long way. So it's not there yet. But to answer your question, I think, you know, what do you do to make behavioral care? I think it's think about the integration with your primary care physician and how all that's eventually going to be mental health and behavioral health are all going to be part of your overall primary health, right? So I think getting the government on board with that, but we're moving in the right direction. I don't know how or when it gets to what you're talking about, it gets to where we want it, but I think we're headed there. We're making progress.
Yeah, I'm glad you mentioned the integration with the primary care because I see that as a big driver for, you know, popularizing to patients who otherwise wouldn't understand how to seek these services, what their options are for services. And we are seeing a lot of integration with the primary care, both in terms of new ventures and just encouraging primary care to really focus on this. Things like chronic care management and recognizing the comorbidities of different types of you know, health struggles that people have. There's a great need. I think we can all agree that the need is huge, but that's also a lot of opportunity for different care modules and different care delivery methods. And so I'm really hopeful that that push for integration that we've been seeing, you know, to a small extent so far really just explodes and really provides a really great avenue until we see some things like government changes, that's something that, you know, on the ground, if you will, is a way to kind of get that change going.
Yeah, when you mentioned some of the hurdles about to overcome about going into a specific space, and there's a lot of research that's known. Like you could look up a lot of the state regulatory, you know, rules and things like that, and Medicaid rates. But then when it comes down to commercial reimbursement, are there ways that you found that were really positive influences on rate negotiations, like value-based care and coordination of care, something like that, things like that, but that they really made a significant difference in commercial payers being willing to negotiate higher rates?
I'll just tell you from my perspective, this is one of the, we talked about before, one of the mistakes, I guess, utilizing your nursing home brain versus behavioral health brain. I think it's definitely helpful to have someone who has the behavioral health experience, either whether it's a consultant or hiring someone who's done it before, because if you haven't seen the other rates, you haven't had the ability to negotiate a behavioral health contract, you're behind the eight ball. You don't know what you could get and what they're trying to take away from you, what should be included, what shouldn't be included. I think that's very important. Making sure you have a strong consultant or someone who's done it before. I would just say from our experience, we've gained a lot from talking to people who, you know, they've seen 100 Anthem contracts versus this is the first time they've seen Anthem behavioral health. As well as like the way that all the payers are set up is behavioral health is usually a different person. So even if you're, you know, your SNF contractor knows how to do contracting, it's usually a different person in Anthem or in United Healthcare they have to speak to. So it's definitely someone who's done it before, understands behavioral health. You're going to get the best value for your contracts.
Yeah, and I would just add, this is more anecdotal. On the lender side, we don't see how the sausage is made necessarily, but from talking with our borrowers, the ones that we've seen be most successful with negotiating higher rates are those that tend to have the strongest back office systems where they're tracking their data and able to go to insurance companies and say, I've treated X number of your patients and here are my results, and engage in more substantive discussions with the insurers. But even then, we've seen it take, you know, quite a long time to be able to enter into contracts a lot of the time. So
I'll just say this does also go into that theme of timeline and reasonableness that we've been expecting. Unfortunately, this isn't something that necessarily will happen very quickly or necessarily will happen to exactly the rates that I think you might be hoping for at the get-go if you don't have that background and experience coming into it. So I would echo, Dove, your point that really having someone who understands not healthcare, not even behavioral health in general, but the services that you are looking for and the reimbursement rates in those states that you're going to operate in is really key to making sure that those are successful negotiations.
I'd add to that, it's unfortunate, but I mean, scale is going to matter, right? So if I'm the payer, if I'm the insurance, and you have 6 beds, and you're going to negotiate with me, am I going to be more, lenient? Am I more likely to give you a better rate or the guy that's treating 6,000 people? It's unfortunate, but you can hire somebody like they're saying, or work with somebody who has that experience and brings that to the table. They have done that on the behalf of other people, and will be able to negotiate much more strongly for you.
That's a great way to start a question. In talking about how the industry is very fragmented today, and you were discussing that, that you're hopeful that some of the states that don't reimburse on the Medicaid level may soon reimburse. On a federal level, have you heard, HUD financing is obviously extremely important to the SNF world and really makes deals happen and creates, much more opportunity out there. Is there any buzz whatsoever for residential facilities that you might have heard of HUD financing becoming available?
I can start. I mean, that's a good question. We at Forbright, we have a HUD platform that's obviously active in the skilled nursing and seniors housing space, but that's a question that we get all the time. And to the best of my knowledge, no. I think it's something everybody's talking about and trying to push HUD on. I think there would be real demand for it, but it's not something that I believe HUD is actively considering at this point. The most we've seen is, a skilled nursing facility that offers behavioral health services, but it's fully licensed as a SNF, is HUD eligible, but that's the extent of what we've seen. So, Joe, I don't know if you've heard.
I know I get there's a HUD lender that sends me like a month, like every couple months, a recruitment letter saying, "Hey, would you like to talk?" And I always get excited and I say, "Oh, is the behavioral health space eligible for HUD now?" And I'm always waiting for them to respond back, "Yes," but they just say, "Oh no, never mind, we're not." So hopefully one day he'll say yes, and we'll go in that direction. I've always been told that people somehow get 120% of the managed Medicaid rate. I haven't seen it yet, so I'm hoping one day I'll be lucky enough to see that. But to my knowledge, I've never seen. I usually give 100% of the Medicaid rate. Sometimes they'll try to start lower than the Medicaid rate. You have to negotiate to the 100%, but I've never seen them give over 100%. I've never dealt with that situation where you have a lower licensure, and you'd be getting a lower rate. So I'm not sure. We've always tied it to whatever licensure we're getting 100% of that Medicaid rate. What is an example you'd get licensed at a lower licensure? Oh, that stinks.
Sounds
Yeah,
like
we don't have that. I'll just keep making smaller locations and just licensing a few beds here and there. But yeah, don't go to New York. Yeah, we haven't had that. And again, in the states we operate, it's they're giving 100% Medicaid rates pretty much across the board.
I have another question for all of us. I would love to know what you guys are most excited for in the behavioral health industry for the next couple years. Is there a specific program? Is there something for funding? What is kind of really exciting for you looking forward?
Consolidation. I'm excited to see what happens. Like, there's a ton of interest, a ton of money pouring into it. Digital health is amazing. What's going on? I have no, I'm not a clinician, so I have no idea if the outcomes and results are as good, better, worse. But either way, I know that there's enough people paying attention to it, putting money towards it, that there's going to be people trying. I'm excited to see what happens there. I'm excited to see insurance payers pay based on quality of work. It's very different from when I started in this industry, and excited to see what happens. I think there's going to be some technological disruptions eventually that are going to be fun to watch.
I think for me, it's seeing improved accessibility. I think we're seeing that in a lot of communities right now, especially seeing, underutilized real estate, like a vacant SNF or a failed seniors housing property, being repurposed as a behavioral health facility in a community where there's significant unmet needs. So it's been exciting for me to see more of those types of projects happening. I think there's more investor capital interested in those projects. Certainly lenders are, I think, increasingly interested in projects like that for the right sponsors with experience. And it's great to see communities that didn't have access to those services have access thanks to improved funding and greater awareness of these issues. So I think that'll be exciting.
I think I'm excited to see, with everyone coming into behavioral health, how the technology and behavioral health is going to transform the care that we give. A lot of the psych hospitals currently are all on paper, and everyone says psych hospitals are 18 years behind nursing homes. So you kind of see how the more people that get involved in the industry, and the more people that are putting their minds behind it and seeing what ancillary services, what technology can really make the care that we're giving a better product. So I think that's, to me, is exciting. We've already seen a lot of that. There's all these products coming out now that can really make the model of care better. So I'm looking forward to seeing that in the future.
How would you respond, Cassie?
I asked the question. I don't have to answer the question, right?
That was a good strategy. I'm going to start asking questions.
You guys know my tricks now. Echoing a lot of what you all mentioned, just the technology and some of the implications for new care delivery and new care access is really, really exciting. I mean, if we even think over the past few years, especially during COVID, but things like mental health services being available on your smartphone. I mean, this is something that now seems really obvious. We do everything on our smartphones. But a couple years ago, that wasn't something that was accessible, and that wasn't something that was widely marketed. And now it's a way to provide really desperately needed services. And it's almost become a second nature in terms of what you can offer for behavioral health as an access point for areas that might not have had access or have had struggles with having enough providers. Things like that are revolutionary. And now with some of the concerns of telehealth, and especially with public health emergency being rolled back, I think there's some uncertainty there for what some of those technologies are going to look like in the next few years. But I think there's also a lot of opportunity, a lot of exciting things that I'm really excited to see how that plays out and see how that increases access even more than we have seen in the last couple of years. So I think that's what's really exciting to me, is seeing how technology will kind of increase that access, but what new care modes and how much easier that'll make access for so many different people. There's a lot of exciting things that are to come in that area.
Is there any scary legal regulation type stuff?
There are
coming?
all the scary legal considerations. Uncertainty is the big thing right now. I think if anyone is at a facility that does telehealth prescribing, you'll know that there's a lot of uncertainty over telehealth and whether or not you can still prescribe via telehealth. Certain care modules and certain aspects of telehealth, things like where your originating site is for telehealth services. Some of those changes from COVID have become permanent. Others have been extended until the end of 2024. Others, uncertainty. And so I think for operators, that's often a really scary thing, is to say, we found a method, we found processes that work for our facility. Are they going to go away? What's going to be the implication? How do we leverage the success we've had with some of these technologies that have been around during COVID and really leverage them for a post-COVID time? So there's a lot of uncertainty. There's a lot of just questions on what is this going to look like? And there's a lot of waiting, which unfortunately, on the legal side, we're waiting too. But it does mean that, with the uncertainty is opportunity. So what we're hoping is that there's going to be a lot of the positive changes that came during some of the telehealth provision during COVID are going to kind of move forward. And the things that are going to be rolled back on the federal side, but also state side, we'll adjust, we'll roll with the punches and just make sure that no matter what, care is still being provided at the highest level.
Yeah, last one.
Ratio. It's going to depend on the buyer, but I mean, 50-50 probably in my experience. What I mean there is, lots of people are going to tell you, lots of buyers are going to tell you, all we care about is culture and the fit, and are you doing things correctly, and that's all we care about. Is that real? No. I mean, we all need to make a dollar, right? So as much as everyone's doing care correctly, they want to provide care, quality care, et cetera, get good results. It's for profit, okay? Well, that's what we're talking about. It's not a non-for-profit. So those things that you just mentioned, those metrics, numbers, locations, all that sort of stuff, that's what matters first to them often. Then how do you get those numbers, right? If you're doing them the way we were, or a lot of people were in this industry 7, 8, 9, 10 years ago, that's not going to fly so well anymore, right? People aren't going to take it. So there is some ethic. There is some people that are saying, hey, I need to see quality care. I need to see no complaints, investigations, no bad marks. I need to see no lawsuits. I need to see all these things. I need to see quality results and outcomes, et cetera. They do care, but I'd say it's probably 50-50 in my experience between those that care about that and those that are just hunting numbers. And I'm not faulting those that are hunting numbers. I'm just saying, to answer your question, the operations are important, but I wouldn't say they're everything. Does that answer it? Okay.
Thank you guys very much.
Thank you all.